Okay, so hi, thank you for the invitation, and apologies for not being able to be there in person. I work at the Boston University School of Public Health in the Department of Environmental Health, and I'm going to be talking today about really different modeling tools to look at linking the built environment, indoor air quality, and health. So can you skip 2 slides ahead? So next one. Some of the questions that we've asked in our research group are things about how, if you make changes in the built environment, for example, how can you measure the impact of home humidification on respiratory virus survival or transmission? How can you evaluate interventions on indoor air quality and health? And by interventions, this ranges from things like integrated pest management, HEPA filters, energy retrofits or weatherization tools, no smoking policies, or the use of humidifiers or dehumidifiers. And then how can we put a cost to this so we can then look at trade-offs between how much costs for the intervention and how much you save or spend more on health. Now, these are all questions that are hard to answer with traditional field or epi studies. So next slide. And the challenges are related to the fact that the indoor environment is very complex. There's multiple trade-offs and positive and negative feedback loops. Diseases are complex, so things like asthma and cardiovascular disease are multifactorial. Some of the health-related outcomes are rare, but cost a lot. So things like an asthma hospitalization doesn't occur very frequently, but when it does, there's a high cost attached to it. And that studies are rarely sufficiently powered to capture effects of the indoor environment on healthcare utilization. That's not to say there aren't a lot of great field studies that look, for example, in asthma at asthma symptoms. So the utility of thinking about these models is really around more rare outcomes like hospitalizations. Next slide. So why is this important, I guess? So the importance is that if you can't prove that there's changes in healthcare due to something in your indoor environment, it's difficult to implement policies or to look at what the costs and benefits are of different interventions. So we turn to system science to answer some of these questions. Next slide. And for those of you unfamiliar with system science, the formal definition is that it's a family of analytic approaches used to characterize complex systems in order to evaluate one or more system problems and identify solutions. So what that means is basically if you have a complex problem, use as many tools at your disposal to be able to explain it. And in our case, next slide, what we're trying to do is build a system science model that links the built environment, indoor air quality, health outcomes, and costs. And you can divide this into 2 types of models. One is building simulations, so that would link the built environment and indoor air quality, and then health modeling. With building simulations, you can model complex airflows. You can look at indoor and outdoor sources. For things like multifamily apartments, you can look at cross-contamination, stack effect, effects of seasonality, different types of mechanical or natural ventilation, and also you can disentangle the individual contributing factors to pollutants. So now in a field study, when you measure PM, you don't necessarily know where it came from, or it's harder to know where it came from, but if you model PM, you can actually keep track of each individual source. On the health modeling side, it would help you characterize the implications of changing indoor concentrations, which is also sometimes hard to measure in an epi study. You can model a large number of participants, which helps you get at the rare outcomes problem, and you can generate data that can help you do cost-benefit analysis. So let's talk about building simulation first. So next slide. Next slide. And there's many tools actually for building simulations. Before I talk about Contam, there's many software packages that you can use to model the indoor environment. You pick the one that fits your question best. So if you're looking at energy saving measures, then the Department of Energy has their Energy Plus energy simulation software with lots of buildings. You can answer questions about energy usage, changes in insulation, et cetera. For us, we're interested in pollutant tracking, and so we use Contam, which is published. It's free to download by NIST. And what you can do with that is it's a multi-zone indoor air quality program, and what it does is it keeps track of ventilation rates, pollutant concentrations, temperature, relative humidity, on a time scale. So as small a time scale as you want, you can keep track of things by minutes, seconds, 10 minutes, etc. You can also track pollutants by room. So you can look at a template and then look at concentrations of contaminants in, the bedroom, the whole apartment, etc. There's around 209 housing templates already made that are available that are representative of most of the housing stock. There's some limitations that it was developed with Residential Energy Consumption Survey and American Housing Survey data that went up to 1997. So newer homes aren't represented. And there's some limitations to the temperature modeling, which is a little, at the moment you can only model temperature by putting in, sort of by pre-setting the temperatures, but there's been work done now coupling the CONTAM to a different program called Transys that does dynamic temperature modeling. So this is what we are using for our models at the moment, or sort of combinations of these different software. But the first example, so skip 2 slides ahead. The first example I'm going to talk about was using CONTAM to look at the impact of relative humidity on influenza virus survival. So we did this in a 2-story detached residential building, so single family. Our indoor moisture sources were cooking, dishwashing, bathing, occupants, and then obviously having a humidifier. You can see the black line is over time, over a day, what the relative humidity was in the house. That tracks with the outdoors. And then when we turned the humidifier on, how that humidity changed. Next slide. And what we used that for was to then, we also modeled there's a person that has influenza that's in the bedroom. These are the typical emission rates. This is how airflows move around the house. We modeled different types of heating systems, so forced air versus radiant. And what we were able to show was that with the increased humidification in the bedroom, if you put a humidifier in the bedroom, that airborne virus survival dropped by 17.5% if it was a forced air system, and by 31.6% if it was radiant. And then there were different modeling scenarios shown on the table. I was a co-author on this paper, and if you want more details, you can look that up. But we also modeled putting humidifiers in multiple rooms, what happened to viruses across different areas of the house, et cetera. Next slide. The second example is looking at the effect of hypothetical interventions on indoor air quality in Boston public housing. So this is, we took one of the templates typical of what would be representative of Boston public housing, and then we modeled different interventions. These interventions were, so we modeled a baseline population, and then we said, okay, what happens if we fix their exhaust fans? What happens if we replace the gas stove? What happens if we don't use the oven for heating in the winter? If we have a no smoking policy, add HEPA filters, have integrated pest management, or if there's weatherization. So next slide. And what you can see in those modeling results, if you look at the top graph, which is NO2, so nitrogen dioxide, it's a combustion byproduct. So if you have a gas stove, that's what you're producing when you have your stove on. And you can see across the x-axis all the different interventions that we tested. On the y-axis is the difference between the baseline population and then what happened at each of these interventions. And you can measure the percentage of NO2 concentration, how that dropped. So we did this for NO2, PM2.5, cockroach allergen, and then dampness, which we then linked to mold. And so there's, again, this was published in 2014. And you can see, for example, for HEPA filters, those don't have an impact in NO2, but they do have an impact on PM2.5. And so we were able to evaluate the relative impact of the interventions on all the different pollutants. Next slide. The third example was actually at a site in Boston, Castle Square Apartments. We actually had architectural, mechanical blueprints, et cetera, that we used to build our own template that was representative of the townhouses there. It's privately owned, affordable rental housing development. And what we were trying to do is to measure. They went through a deep energy retrofit. So they put insulation, changed the windows, changed the appliances, the doors, air sealing. And we were trying to measure what the impact of that was on indoor air quality and then on health. Next slide. So one interesting thing about this project is we could also capture a lot of things about resident behavior. So just looking at the top line, which is if you have a heavy smoker and a heavy cooker, across the x-axis are all the different scenarios that we modeled, so baseline. On the y-axis you have PM 2.5 concentrations, which could be any pollutant. You can see that if you go from in the heating season, which is that first panel, cooling season is the second panel. The first thing to note is that the concentrations are really different. The reason is that during heating season, the HVAC system has a filtration system, a filter in it, and so it's reducing PM 2.5 concentrations. Whereas in the summer, there's no filtration system, so it's only natural ventilation. So that's a difference in concentrations. And then what you can do is say, okay, if you have no retrofits from the baseline, this is your concentration. If you weatherize, concentrations go up. If you weatherize and use your exhaust fan, concentrations drop. Use filtration, etc. So, and that top line is for a heavy smoker, heavy cooker. You can see that there's different color lines for different types of behaviors. And the dotted red line would be if you open your windows. So you can also model what happens with all these different behaviors that residents have. Now, if you open the windows and you have your gas stove on, maybe you reduce PM 2.5, but maybe you increase outdoor air pollution, allergens that might be outside coming in. So you have to think of all those trade-offs. This particular example just covers indoor PM 2.5. Next slide. That covers the building simulation piece of this system science model that we're putting together. So now I'm going to talk about the health modeling, which then links the indoor air quality changes to health and then costs. I'm going to do this in the context of asthma, which is one of the diseases that I've worked the most with. So next slide. So just quick, asthma is a chronic lung disease that inflames and narrows the airways. It causes wheezing, chest tightness, shortness of breath, and coughing. Prevalence has been increasing in the last 10 years. There's about 20 million people in the U.S. with asthma and about 7 million children. And the highest rates of asthma are recorded in the urban poor. Now, although we don't know what causes asthma, there's still a lot to be found out for what causes asthma, we do know what causes asthma exacerbations. Next slide. And a lot of the pollutants that can cause asthma exacerbations can be found indoors. Indoors, obviously, very important. We spend most of our time there. You can be exposed to outdoor air pollutants that infiltrate in combustion byproducts from cooking, either from the cooking itself or from burning gas on a stove, environmental tobacco smoke if you have smoker indoors, and then there's this large category of biological exposures. So things like allergens, that's a dust mite, a cockroach, and a mouse. Things like pollen that would come in from the outdoors. Fungi could come in from the outdoors, or it could be growing on building materials and gets into the air. And then viruses, which would be coming from humans living in the home. So all of these can be risk factors for asthma exacerbations. Next slide. This is how we combined our system science model. It's a discrete event simulation model. Discrete event simulation is an approach that models a complex system that evolves over time, given changes in state variables that occur at defined points in time. What does that mean? You can model children, asthmatic children, and march them through the day, assign them characteristics that change throughout the day, characteristics about themselves. So, for example, lung function, characteristics about their homes, characteristics about what their exposures might be. And you march them over time and change this, and then measure their exposures, measure their changes in lung function. Their changes in lung function are going to produce changes in probabilities of asthma attacks. You can keep track of their asthma history, for example, asthma medication. Our model also included, like I said, cockroach, allergen, and mold. But you can expand this to any pollutant, really, as long as you have the right linkages to link to the model. And you can think of this as a cumulative risk assessment problem, because in cumulative risk, you're trying to see what is the impact of multiple chemical, non-chemical, biological stressors on a health outcome in someone. So it's a system science tool, but at the end of it, it's also a cumulative risk assessment tool. Now, how do we parameterize all of these different linkages. Next slide. There's many, many ways. So, for example, for the building, we talked about building your own templates or choosing from available templates. For outdoor weather or pollution, you can do land use regression models, use remote sensing data, use weather or monitoring stations. For occupant behavior, you can do a field study and get specific behavior to a site that you're studying, or you can look at the EPA CHAD database, which has a lot of information about typical behaviors and how much time people spend doing what. In order to validate, you need to have some information, so you can get that from field studies along things like air exchange rates or indoor air quality parameters. To parameterize the kids, we've mostly used survey information before, but we're actually starting to work with electronic health record data from the Boston Medical Center to try and find profiles of kids that we can use also to parameterize the model. For the linkages between all these exposures and lung function, we can look at epi studies. We can also look at electronic health records for things like asthma medication, compliance, prescription, and how that changes the relationship between your lung function and your asthma attacks. And then finally, that lung function health outcome relationship can, again, come from epi studies, which is what we've traditionally done, or, again, from electronic health records, which is what we're working towards. And then once you have this all built up, you can model anything you want. You can tweak any piece of the model that you need to test different theories. And then you can calculate costs at the end of it. So I'm going to just show a couple of examples of how we've used this. Next slide. The first one is that deep energy retrofit that I talked about before in Castle Square, where we built up our own template. We had survey information to parameterize the people, the blueprints to parameterize the buildings, and then we used EPI to make the links between pollutants, previous health, asthma history, medication, et cetera, and asthma outcomes. Next slide. In that case, we modeled 100,000 asthmatics over 10 years. So the beauty of this is you can model as many children as you want, 1 million kids, 10 million kids. You do need to use distributed computing, meaning if you do run the model for 100,000 asthmatics, you need to split it up into multiple jobs and send it out to a server, because if you do it on your computer, it will take a really long time. But then what these results showed, this is asthma outcomes, and on the y-axis you have the change in asthma outcomes compared to the baseline. The baseline was pre-deep energy retrofit, so pre-weatherization, and with the exhaust fans off. So if you look at those first three sets of columns, it's post-retrofit, so after the weatherization, still not using the exhaust fans, and then across three categories of smokers, none, light, and heavy. And you can see that there's reductions in asthma outcomes no matter what category anybody was in. So if there was a smoker, whether there was no smoker, a light, or a heavy smoker, the fact that these weatherization included a filtration system, an exhaust fan, well, that wasn't used. Basically, it was a filtration system. It reduced particle concentrations and allergen concentrations enough that you could measure decreases in the asthma outcomes. Now, if you turn the exhaust fans on, and that's that second set of columns, you can see that that impact is much higher. Why? Because it's a point source exhaust fan, right, that gets rid of NO2 and PM 2.5 as it's getting generated. The other interesting thing about this is that the biggest impact is in the heavy smoking household, and that is because you're starting with a bigger baseline of pollutants and you're reducing it, that you see a bigger benefit. Next slide. The second example I'm going to talk about is the Boston Public Housing that I talked about, of all these interventions that we tested, so the fixing the fans, replacing the gas stove, et cetera. We parameterized this with typical Boston Public Housing characteristics. So next slide. And we can skip that one. Next slide. And then this graph should look familiar, except instead of NO2, we have asthma symptom days and severe attacks. And again, we're looking at the percent change in health outcomes for each intervention compared to the baseline scenario. So now you can look at your health symptoms and say, if we fix the fans, it looks like there's a 2.5% decrease in asthma symptom days and maybe a 7.5% decrease in severe asthma attacks. You can go along all the interventions. If you weatherize, for example, you can see that there's an increase. Why? Because you're tightening up the building without doing anything to compensate to reduce indoor pollutants. If you add a cost to this, so if you go to the next slide, we then took information from the Red Book and the asthma healthcare expenditure values, and we put a number to that. And so you can see that if you fix the fans, the yearly amount of money that you will save per asthmatic is around $165. And then, again, across each intervention, you can figure out how much money you will save or how much more you will have to spend on healthcare costs. If you go to the next slide. So how is that useful? Let's go through an example. If it costs you around $300 to $550 to install a fan and you save around $173 per year, then within 2 to 3 years, you will have, that's the payback period. You will have broken even, right? And then any other savings in healthcare will be a benefit. Now, there's an argument there on who pays for the fan, who pays for the hospitalization bill, who pays for medication that I'm not covering here. But in absolute numbers, it seems like putting in exhaust fans is a very cost-effective way to reducing healthcare costs. If you go to the next slide. The second example is now weatherization. And this is an intervention cost of, say, $6,500, which might cover air sealing, insulating, and maybe replacing some windows, but not too many. You have an increase of $314 per year, so you're spending more because you weatherized. You have an energy savings of $605 per year. So usually when weatherization programs happen, they only present, okay, if you do this weatherization, we're going to be able to save this much money in energy costs. So if that was $605 and the intervention cost was $6,500, then the payback period, without considering health costs at all, would be 11 years. But if you add in the extra amount of money that someone is going to have to spend on asthma hospitalizations, medication, et cetera, then the payback does not look so good. It's 22 years. So this is a type of analysis that you can do with these models, and then sort of link them back to whatever interventions you might be interested in. I always put this in my presentations. It's a model, which means it's only as good as the inputs that it has, as the connections, and as how well you can validate it or evaluate it. So just to remember that these numbers aren't absolute. Next slide. So in conclusion, I hope that you saw that system science tools are useful in evaluating these complex exposure outcome relationships across all different kinds of pollutants. So you can use it for viruses, fungi, combustion byproducts, bacteria. You can include social stressors in all different kinds of health outcomes as long as you have all the linkages in place, and you can do these cost-benefit and policy analyses. Next slide. So just quickly acknowledging, obviously all this work does not happen without a really talented team and funding, and that's the end of my presentation. Any questions?